Good morning and Assalamu alaikum. Welcome you all on our today's session on ECG series on supraventricular tachycardia. We are very lucky that we have today our speaker is Dr. Rafique Ahmed sir, a very well-renowned doctor and consultant cardio electrophysiology, MedStar Heart and Vascular Institute in USA. স্যার আপনার অনুমতি পেলে আমরা আজকে শুরু করতে পারি।
Let's get started. So are we live? Right. Good morning. So I'm sorry we had to start early today because I have another talk at 10 a.m. in Bangladesh. We're going to talk about supraventricular arrhythmia. Normally I make it interactive. If you have any question, please ask me. Today I may not ask questions. So supraventricular arrhythmia means anything coming from above the ventricle. So this is an ECG. You can see it that there is P wave before each QRS complex, and a normal PR interval, normal QRS duration, QT interval. P wave axis is normal, so it's normal sinus rhythm, normal ECG. So what happens with P wave? So if I have taken all these P waves and relocated them in different location. If you look in here, that P wave starts from here and it comes downward. So it is upright in lead 2 definitely, lead 3, and in lead AVF and lead 3. AVR is in the right corner, so the electricity is moving away from it, so it's negative. And lead 1, it is moving towards lead 1, so it's positive. And then I have taken the P waves from the chest lead, V1, V2, V3, and V6. You can see that this electricity is coming towards V1. So we have a positive component. And then it goes to the left atrium. That means it is moving away from V1. We have this negative part. For V2, it's mostly positive, and V5, V4, V5, V6, these are all positive then. So that's the way P wave is inscribed. And P wave is difficult to see, but we can plot its axis and really find out where it's coming from. So this is a tachycardic rhythm, and you can see there is P wave before each QRS complex, and the P wave is upright in lead 2, 3 AVF and lead 1, and negative in AVR. So this is sinus rhythm with sinus tachycardia. And I'm not talking about this. There are STT wave changes, but we're not going to discuss this today. This is heart rate 45 beats per minute. Again, there is P wave before QRS complex, and the P wave is upright in lead 2, 3 AVF, lead 1. So it's sinus rhythm, normal PR interval, normal QRS duration, normal QT interval of, and then a normal QRS axis. So it's except for sinus bradycardia. So my reporting will be, this is sinus bradycardia, otherwise normal ECG. So this is another one that we have shown before, that again, the rate in this case, this is a 17-year-old female, 66 beats per minute. Interesting that some people will use 1 RR interval to measure heart rate. Now, if I measure it here, it'll be too fast. If I measure it here, it's too small. So what I did, I measured the whole page, which is 10 seconds. We have 11 beats there, and times 6, that gives a heart rate of 66. And there is P wave upright in lead 1, 2, little bit flat in 3, which can happen, then upright in lead AVF. There's sinus rhythm, normal PR interval, normal QRS duration, and QT interval. But there is a irregularity in here. But if we look at the irregularity, you can see that this is slow and becomes fast, then slow and fast. And it has happened twice in 10 seconds. And in 1 minute, it is 12. So this is same rate as the respiration rate, and this is sinus arrhythmia, which is very common, especially in young people. This is a 17-year-old female. You expect that. So this is an irregularity. That's a normal finding. So the report will be normal sinus rhythm with sinus arrhythmia, normal ECG. How many participants have we got today?
Sir.
How many?
30 জন আছেন তার জন্য
Anybody wants to answer? Anybody wants to answer this ECG? Dr. Murad?
Yes, sir. Assalamu alaikum.
Awesome. So I'll tell you the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9. 78 beats per minute, and then you tell me rest.
In this ECG, sir, P is inverted to 3 AVF, and QRS P wave.
So where is the P wave coming from? Is it sinus?
No, sir. P
Okay,
is inverted, not sinus
Okay,
rhythm.
so where is it coming from? I'm just asking, is it coming from the lower part of the atrium, upper part of the atrium? Where do you think it is coming from?
Sir, it is not upper part of the atrium.
Why do you say that?
Because P is inverted in 2-3 AVF.
Yes, so that means it is moving away from 2-3 AVF, so it's on the inferior part of the atrium, right?
Yes, sir.
So you can call it low atrial rhythm. Fine. So it's an atrial rhythm.
Low atrial rhythm. And
yeah.
Otherwise, sir, no, normal. Low atrial rhythm and other findings.
Yeah, PR interval is normal. QRS duration is normal, but not really normal. If you look at the T wave, they are biphasic. In lead V5, it's a little bit negative positive, right?
Yes.
And same in lead 2, lead 3 AVF. What is the significance? I don't know, but there is abnormal. So your diagnosis is left atrial rhythm, T wave changes, right?
Yes, sir. Yes, sir.
Good, good. So now let's look at it. So what I have done is I have actually taken these P waves and I have put it here. Look at what's happening, Murad. So this is 2 is negative, 2 is negative, 3 is negative, AVF is negative. Interesting, if you look at it, lead V5 is negative. P4 is negative, V3 is negative, V4, V3 is negative. So this ECG is moving away from V6, so it must be on the left side. Here V6 is negative, V4, V5 negative, V3, and then V1 is positive. So that means it's actually a left atrial rhythm. I mean, if you can tell just atrial rhythm, that's good enough. If you can tell left atrial rhythm, that's fantastic. But you did good. Thank you.
Thank you, sir.
Murad, do you understand the concept of this?
Yes, sir. Yes, sir.
Yes. So when you look at an ECG, you have to think in 3 dimensions. And that's what I did with this picture, just to give you some idea that when you put a look in 3-dimension view, you can actually visualize that this P wave is moving away from V6, so it must be on the left side of the heart. So it's a left atrial rhythm. This is a very common ECG given in exams, and people are expected to answer this correctly. So supraventricular arrhythmias, anything that comes from the top chamber of the heart, above the ventricle. So there are different types. You can have, the commonest supraventricular arrhythmia is actually sinus tachycardia. And then you can have sinus node reentrant tachycardia, which exactly looks like sinus tachycardia, but they will start and stop suddenly. So that's the difference between sinus tachycardia and sinus node reentry will be, sinus tachycardia will gradually go up and gradually come down, but sinus node reentry will suddenly start, suddenly stop. Then you can have AV node reentry. There can be reentry in the AV node. You can have atrioventricular reentry using an accessory pathway. You can have intra-atrial reentry and in the atrium, atrial flutter, which is also a reentry circuit, and then atrial fibrillation. Atrial fibrillation is totally chaotic rhythm. The difference between all this is atrial fibrillation is always irregular. So if a rhythm is totally regular, then it is definitely not atrial fibrillation. So please remember that point, that a rhythm that is completely regular is not atrial fibrillation. So I want somebody to do this ECG with me. Anybody?
Mahmudul Hassan. Mahmudul Hassan, Dr. Shudin Das, Dr. Shafiqul Islam. Okay, Shafiqul Islam hat tuleche. Shafiqul Islam. Shafiqul Islam.
Assalamu alaikum, sir.
So I'll give you the heart rate. Heart rate is 90 beats per minute. And you tell me the rest.
Sir, rhythm is irregular.
Perfect.
There is no P wave seen before QRS complex.
Okay.
The QRS duration is 80 milliseconds.
Yes.
And there is no ST-T wave changes.
Yeah, not significant. Yeah. So what is your diagnosis?
Sir, my diagnosis is atrial fibrillation.
Yeah. So atrial fibrillation. Perfect. And if you can tell the ventricular response is controlled, that means heart rate is under control. That will be a good thing to do. But if you tell diagnosis just atrial fibrillation, that's good enough. So what is your name?
Shafiqul Islam.
Shafiqul Islam. Oh, good. So the point is the irregularity. Extremely irregular. Shafiq, stay with me.
Yes, sir.
So this is another one. You can see again, extremely irregular RR interval, and there is waves, which is like fibrillatory waves. Over here, it may look like flutter, but it is not. It's fibrillation. So irregular RR interval. So and same patient when it's kind. What do you think of this, Shafiq? Is it regular or irregular?
Sir, looks like a regular.
Yes. So looks regular. But this is the part that when atrial fibrillation becomes very fast, it may look regular. But look at carefully. This interval, you can see my pointer, right?
Yes, sir.
It's actually shorter than this one. And
Yes.
This is different. But if you suddenly look at it, it may look regular. And I have begun bigger picture of this. Now we can see the irregularity, right?
Yes.
So
Sir.
please keep in mind that atrial fibrillation, when the rate gets too fast, it may look regular. But even when it looks regular, if you put a caliper over it, you will find that it is irregular. So again, same. This is atrial fibrillation with rapid ventricular response and non-specific. Good. Thank you.
Thank you, sir.
Anybody wants to do this one?
নতুন কেউ মোহাম্মদ সাইফুর রহমান ওকে আপনারা যারা একটু আনসার দিবেন অন্তত আপনাদের ভিডিওটা একটু অন করেন যাতে আমরা আপনাদের সুন্দর চেহারাটা একটু দেখতে পারি
Yes. The heart rate, I'll tell you, it's about 135-40 beats per minute. So this is definitely tachycardia. Nobody?
সাইফুর রহমান এক মিনিট স্যার সাইফুর রহমানকে প্যানেলিস্ট আনতে হবে স্যার এক মিনিট
Okay.
হ্যাঁ সাইফুর রহমান ইউ আর ইন প্যানেল নাও
Saifur?
সাইফুর রহমান
Hello.
Hi.
Hello, sir. I was having some. Okay. Assalamualaikum, sir. I'm Mohammed Saifur Rahman.
Okay. So I'll give you the heart rate is around 125 beats per minute. So
Okay,
this
sir.
is definitely tachycardia, right?
Right, sir.
So now question is, what is it?
After the heart rate, we check the rhythm, and
Yeah,
the rhythm appears regular.
regular. Good. So
And
if it is regular, what is this is not?
I'm sorry, sir, I didn't get the
You
question.
said the rhythm is regular, right?
Right, sir.
And if it is regular, you can exclude which rhythm?
Mm, atrial fibrillation.
Exactly. So this is very important. Once you have determined and if you measure it, this is actually extremely regular. This is definitely not atrial fibrillation. So now what is this one? What are the possibilities?
Sir, some of the possibilities are, sir, atrioventricular nodal reentry, supraventricular tachycardia,
Okay,
sir, atrial tachycardia,
atrial tachycardia.
sir, sir, others,
One more,
one more,
atrial flutter.
atrial flutter, sir, yes, sir.
Yes, and the rate is 125. It can also be sinus tachycardia, right?
Right, sir.
Okay, now which one do you think it is? So definitely. So you actually went through very good point. First of all, you determine the rhythm is regular. So it is not atrial fibrillation. Rate is around 125. So and these are all the possibilities. Supraventricular tachycardia, atrial flutter, and then we said sinus tachycardia. So which one do you think it is?
Sir, I think this one, um, P wave, sir.
Oh, next thing you look at, do you see any P wave?
No, sir, I can't see any P wave, sir.
Where are you looking? Which lead?
Sir, so lead one, lead two,
Okay, lead one is totally useless. How about lead two?
lead two. The P wave appears, sir, inverted.
Exactly. So you see, so what you do, if you look for it, then you will see it. So you think this is the P wave?
Uh,
Possibly, right?
Possibly, maybe.
Yeah, that's what you are thinking, right?
Yes, sir.
Yes. Okay. So you saw a negative P wave before the QRS complex. So it can be an atrial tachycardia. But do you see any other P wave?
No, sir.
Okay. In your mind, ignore the QRS complex. Just
Okay.
erase the QRS complex in your mind. What does it look like? Does it look like a saw?
Yes, it looks like a saucer.
Exactly. So this could have been a T wave, but in my mind, if I imagine this without the QRS complex, it looks like the saw. If it is a sawtooth appearance, what is it?
It's the atrial flutter, sir.
Okay, atrial flutter. So what I did, I actually on purpose removed part of this ECG. And you can see this. See, here now, if this is lead 2 that you are looking at, you can see the flutter wave here. You see that?
Oh, yes, sir. I see that.
So anytime you see this ECG, so this is a good way of analyzing, look at regularity or irregularity. If it is irregular, it is not atrial fibrillation. Remember, if it is irregular, it can still be atrial flutter or something, but FIB cannot be regular. And then once you have seen this regularity, we now want to determine if there is a P wave. And you said there is a P wave, and then you imagined another P wave. And then if you put calipers, you'll find that these P waves are marching through. And then you came to the diagnosis of 2-to-1 atrial flutter. And of course, if I have the advantage of this one, I know it is atrial flutter. Now this rate was a little slow, 114 beats per minute. Most atrial flutters will be at a rate of 150. If you see a narrow QRS tachycardia at a rate of 150 beats per minute, always think of atrial flutter. I gave this one purpose, just to confuse people or just to give a thought of thinking process. that, yes, like, that's what it was. Thank you.
Thank you, sir.
Anybody else want to do this one? This is again a heart rate of 154 beats per minute. We'll go through the same thinking process. Anybody, any volunteer? We should not waste too much time in between looking for volunteers, but it makes it more fun.
Assalamu alaikum, sir.
Who is this?
Sir, Dr. Mahbuba.
Mahbub. Okay, Mahbuba, please do this. I gave you the rate is 154 beats per minute.
Yes, sir. Sir, here, sir, rhythms are regular.
Regular. So it is not atrial fibrillation, right?
No, sir. Ji, sir. No atrial fibrillation, no, sir.
Okay, not atrial.
And sir,
so what,
here, sir, rhythm regular, and sir, here, sir, the P wave, sir, like sawtooth appearance in lead to AVF.
maybe, but where is the second saw? It's not like the other one. But here, look at lead V2.
Yes, sir.
Is there a P wave there?
Sir, inverted.
No, in lead V2. V2.
Yes, sir. Here, P wave, sir, present, sir.
Upright, right? So
It's upright.
there is a P wave, and there is a P wave before QRS, right?
Yes,
before P wave. So, and when you say a P wave before each QRS complex, what do you think of?
Sinus.
Tachycardia, right?
Yes, sir. Sinus tachycardia.
But the problem of sinus tachycardia is for 154 beats per minute, sinus tachycardia, that's too fast for sinus tachycardia. It can happen if somebody is running, right? Or somebody is very sick.
Yes, sir.
So anytime I see this P rate, now if you see this, do you see another P wave?
Sir, another P wave, sir,
Look here. Over here one, over here one. And I look in between, maybe this is a P wave.
V2.
You
Yes,
see?
sir.
So,
Yes, sir.
and then lead 3, you can see this saw, but you cannot see the second one. I am thinking this is probably, if my calculation is correct, there is a P wave before QRS, P wave before, there is a one in the middle. Because normally in lead VT, you don't see anything like this. So what is diagnosis now?
Sir, probable diagnosis means, sir, it may be atrial flutter, supraventricular. No, sir.
No,
Supraventricular
atrial
tachycardia,
flutter.
sir, PF absent থাকবে.
No,
flutter, sir.
not necessarily. But as I can see 2 P waves for each QRS complex, so it is most likely atrial flutter with 2-to-1 conduction. The other possibility, atrial tachycardia. So let's see what happens with this. If I have another one on this. So it can also be supraventricular. The same patient, look at this one, the rate slows down. Now you can see the sawtooth, right?
Yes, sir.
Yes. So look at lead V2 that we saw before. See these positive waves? So diagnosis of arrhythmia, it always requires a little bit of imagination. So I could have been happy with this diagnosis that this is P wave before each QRS sinus tachycardia, but then I thought this is a little too fast for sinus tachycardia. And I started thinking, is there another P wave? I said, well, maybe this is another P wave. And that's how we go by. And then of course, this is 8th of January, by probably patient got medication, and next day, 9th of January, rate slowed down, and you can see this typical sawtooth appearance, atrial flutter. So atrial flutter with 2-to-1 conduction. Any supraventricular tachycardia rate around, thanks Mahbuba, rate around 150 beats per minute, please think of atrial flutter. So this is another arrhythmia, I'm going to do it. If you look at P wave, QRS, and then there is a QRS complex. P wave, QRS, and then there is another QRS. And I think there is another P wave here. So there is a P wave, there is a premature beat. This is atrial premature beat, then sinus rhythm with atrial in a pattern of bigeminy. So frequent supraventricular premature beat in a pattern of bigeminy. And then this beat is white QRS. And people may think this is a ventricular premature beat, but not. This is actually a supraventricular premature beat with aberrant ventricular conduction. Over the next few sessions, we'll come back again to this kind of ECG. So this is another ECG, a rate of 101 beats per minute. And see, if you look at the computer, it has reported sinus tachycardia with first degree AV block with occasional ventricular premature contraction. And the reason it mentions sinus tachycardia is, you can see the P wave here with first degree AV block, long PR interval, lead 1 upright, lead 2 upright, lead 3 possibly upright, AVF upright, and 3 maybe, we don't know. So this computer diagnosis, and actually this was confirmed by cardiologist also as sinus tachycardia, which is not unusual. But my problem was that I looked up all the ECG on this patient and rate was again 100. Please remember one thing, that if you see a patient with tachycardia around 100 beats, 110 beats, and it remains constant for few hours or few days, it can never be sinus tachycardia, because sinus rhythm will never stay in one place. It will be either 101, 105, 98, 97. So there will be variability of sinus, but only a supraventricular tachycardia can vary. And I thought maybe it is an atrial tachycardia with 2-to-1 conduction, but I had to prove that. So I found another ECG of this patient. This is 6 January 2005. And I looked at the computer. I found another ECG February 2003. And here again, if you look at this, it looks like P wave, QRS complex, lead V1, biphasic P wave. And so it looks like sinus rhythm with first degree AV block. But if you go and find a place where there is slowing of conduction, you can see that this was an atrial tachycardia. And it was conducting 2-to-1 in a way that it looked like sinus tachycardia with a rate of 101 beats per minute. So this is another rhythm that this is a tricky. This one, you can see that there is a rhythm, faster rate, and then it stops, and then there is again faster. And the morphology of the P wave, the slow one and the fast one is same. And I thought this was sinus node re-entrant tachycardia. Unfortunately, there is no way of proving or disproving it. Only way I can tell that this is possibly sinus node re-entry, because the morphology of the P wave was exactly like sinus P wave in V1 biphasic, upright in 2-3 AVF and lead 1, and it was starting and suddenly stopping. If it were sinus tachycardia, it will not suddenly stop. It will gradually slow down and then gradually become faster. So this most probably was sinus node re-entrant tachycardia. It is not uncommon arrhythmia in older patients. It doesn't have much of a clinical significance, except that you have to differentiate it from atrial tachycardia and other rhythm problems. So again, I'm coming back to this old diagram that I showed you, that you can have re-entrant tachycardia in the AV node, you have re-entrant tachycardia in atrioventricular re-entry using an accessory pathway. The tachycardia we just saw was a sinus node re-entrant tachycardia. And atrial flutter itself is a re-entry circuit. This has shown a small re-entry, but atrial flutter is a macro re-entrant circuit. And the atrial fibrillation that we saw were multiple re-entry in different locations of the atrium, giving rise to a chaotic rhythm. So what we look at...
Sir, a question is, why atrial fibrillation is always irregular?
Oh, the question is, why is atrial fibrillation irregular? Okay. So atrial fibrillation has multiple wavelets. So if you believe in the wavelet theory, so there are multiple small re-entrant circuits, and all of them try to go through the AV node. So it will be like if you put 10,000 people in Dhaka Stadium and open the gate and tell them to run out of the room, of the gate, they will try to go through that gate in a very chaotic pattern. And they will not come out in a regular sequence, because what will happen, everybody will jam. Let's say in the stadium there is a fire, everybody will try to go out. And what they will do, they will block the gate. Some of them will go out, so they will not come out faster. On the other hand, if I take an atrial flutter, they go in a regular pattern. One goes out, one stops. Next goes out, next one stops. So it goes in a regular pattern. That's why it's regular. And that's why atrial fibrillation is irregular. And there is bombardment of the AV node through different locations. Does it answer your question? Who asked the question?
স্যার ফ্লাটারের প্যাথোজেনেসিসটা তাহলে কি দাঁড়াইলো? আমি একটু যদি ক্লিয়ার হতে চাই, মানে ফ্লাটার এবং ফিব্রিলেশনের প্যাথোজেনেসিসটার ডিফারেন্সটা কি তাহলে?
Yes, flutter actually is a one re-entry circuit, a macro re-entry. Fibrillation, mechanistically, it has multiple re-entry circuit in the atrium. So, and the re-entry circuit will be firing at a rate of 500 to 700 beats per minute. So the mechanistically, they are totally different arrhythmia.
Okay, sir. Thank you.
Okay, now you remember that we talked about looking at the morphology of the P wave, which is important. Once we determine the tachycardia, we can look at the P wave location. This is ECG and this is esophageal electrogram. So AV node re-entry, what will happen? The P wave will be inside the QRS complex, so you will not see it, or you can see it immediately after the QRS complex. If you see the P wave a little bit after the QRS complex in the ST segment, RP shorter than PR, that's most likely atrioventricular reentry. On the other hand, if you find that the P wave is before the QRS with the long RP, what you call long RP tachycardia, this is either atrial tachycardia or sinus tachycardia. And if the P is upright like this, or if it is negative, this is AVRT or atypical AV node reentry. So we'll come to this formula. So this one, somebody wants to do this one? Heart rate 174 beats per minute.
Dr. Saifullah. Dr. Saifullah Razin, please. নতুন কেউ?
Dr. Salahuddin. Is Dr. Salahuddin there?
Yes, sir.
Unmute
Rhythm is
yourself.
regular.
And heart rate is 174, so regular rhythm.
Yeah. And
Okay.
every P wave is followed by QRS.
And where do you see the P wave? Which lead?
Lead 1.
Okay. And which other lead?
And AVL.
Lead 1 and AVL. Okay, which one is better P wave you see? Lead 1 or AVL?
The lead 1.
Lead 1. So this is, you are thinking of this is P wave, but if I say, well, this is the end of the T wave, how will you justify that? So it's a possibility, right? That this is end of the T wave. How about lead 3?
Yeah.
Maybe a P wave, right? This one?
Yeah. But
okay.
Their P wave is inverted, seems to be inverted.
Inverted in lead 3, right?
Yeah.
How about lead AVF? Maybe inverted, right?
Yeah.
So what do you think? So there is is it PR longer than RP, or what do you think it is?
PR is longer than RP.
No.
No, sir, inverse. RP is longer than PR.
Exactly. Long. Okay. So this is a long RP tachycardia, right?
Yeah.
So I'm going to go back. Where does it fall in this?
Long RP.
Here,
Sir,
right?
yeah. Active tachycardia.
Yes. So long RP tachycardia. So it is either atrial tachycardia or atrioventricular ANT. So look at it. So, and it is a kind of biphasic P wave. So your diagnosis, what is your diagnosis? Atrial tachycardia?
Yes, sir.
And what is your differential diagnosis?
AVRT?
AVRT and AVNRT, right?
Yeah.
AVNRT. Do you think it can be atrial flutter? Do you think it can be atrial flutter with 2-to-1 conduction? It can be, but it is a little bit too fast, because if it is atrial flutter 2-to-1 conduction, that will have to be like 350, close to 350 beats per minute, right?
Yeah.
So how am I going to distinguish this? What can I do to distinguish this arrhythmia?
To slow the heart rate.
How? Any
Beta
medicine you
blocker
want to?
IV adenosine.
Okay, good. Adenosine. Have you ever given adenosine?
Yes, sir.
How do you do it?
So with rapid flash, normal syringe, rapid flash.
Exactly. Adenosine half-life is 9 seconds. So when you inject it, inject it and then quickly flash. The best way to give adenosine is to connect a 3-way stopcock, one syringe with adenosine and another 20 cc flash, and if possible, elevate the arm. Look at this. What we did, we gave this patient adenosine. Adenosine, what happened? Tachycardia slowed down, but you can see the P wave.
Yes, sir.
What do you think the diagnosis? Your diagnosis is confirmed, because what happened? Adenosine blocked the AV node, but did not stop the tachycardia. If it were AV node reentry, atrioventricular reentry, it would have stopped. So this is clearly an atrial tachycardia. So the summary of this is that you have a narrow QRS tachycardia, which is a long RP tachycardia, with kind of biphasic or inverted P wave in inferior leads. So that made your diagnosis of atrial tachycardia most likely. Alternate diagnosis could have been an atypical AV node reentry or atrioventricular reentry. But once you give adenosine and that QRS, there is no QRS continuation of P wave that confirms the diagnosis of atrial tachycardia. Thank you.
স্যার ডাক্তার সালাউদ্দিনকে আজকের একজন উইনার ঘোষণা করা যায় স্যার।
Yes.
আর দিছো বাইরে, ঠিক আছে, মেনে নিলাম। পানিও দিয়ে দিতে হবে কেন?
And Murad did good.
Murad always did good, sir.
Okay.
He is a star.
Okay. So somebody to do this one.
মাহমুদুল হাসান আমিন হাত তুলেই ফেলছে, দেখি।
Okay. Mahmoud.
Mahmudul Hassan Amin, you are in panel, I think.
Yes, sir. Sir, the rate is 132 almost.
Yes. Okay.
And the P is inverted in lead 2, 3, and also in AVF.
Okay.
And PR interval is square গুলো বুঝতে পারছি না, তবে
yeah, it's difficult. So it looks normal. It looks normal. So
it looks
is a long
yes,
RP tachycardia, right?
Right, sir. Long RP
Okay.
tachycardia.
So what is your diagnosis?
Sir, it may be AV nodal AVRT or AVNRT.
Okay.
So Dr.
Right.
Mehnaz Firdaus want to participate in this ECG.
Sure.
Dr. Mehnaz Firdaus, please. ওর যেটা আনসার সেটা হচ্ছে জাংশনাল ট্যাকিকার্ডিয়া।
Yes.
Dr.
Okay.
Mehnaz Firdaus answer.
Junction tachycardia. Okay, fine. So both of them actually are saying the same thing. If it is AV node reentry, it's an atypical AV node reentry, or junctional tachycardia same. So if it is junctional tachycardia, the way it will happen that the impulse will originate near the AV node and it will go backward towards the top of the heart. So it will make P wave negative in 2-3 AVF. But it is coming from the middle of the heart, right? If that was the case, it will go towards V6 and V6 will become positive. But here, V6 is negative. V5 is negative. That means this impulse is moving away from V6. Now that I told you that, what do you have any correction for your diagnosis?
Sir, this wave is come from left side atrium.
Exactly. So
Left atrial tachycardia.
exactly. So, but your both of your diagnosis of junctional tachycardia is actually valid diagnosis based on 2-3 AVF. If V6, V4 was positive, V5, V6, then I would have carried that diagnosis, but it is not. It is negative. So having V4, V5, V6 negative makes it a left atrial tachycardia. Thank you. So what I'm trying to do with this, that we are actually trying to instill in you a process of thinking. Remember that nobody will be able to give exactly correct answer if challenged unless we can see the waves. But the whole point of being able to analyze is what is important. Like if this P wave was upright, we'd have thought differently. Thank you. This is another rhythm. I'm not going to say the same patient, when it converts back to sinus rhythm, you can see now that clearly P wave is upright in 2-3 AVF. Biphasic kind of funny wave in AVL. So this is another patient. You can see P wave and then a bunch of QRS complexes. We don't know what they are. But so when you see something, you just leave that and go for places where you can see things. What I know that this is P wave QRS, P wave QRS, is sinus. So here I can see something here. So I think this is a short run of atrial tachycardia. Why am I saying that? Because if you look at the T wave here, and T wave here, it's a little distorted. Probably there is a P wave. There is another P wave probably buried in the QRS complex. And how do I know that? If you look at lead V1 T wave, this V1 is little distorted. So this is the P wave that conducted. This is the P wave that conducted. This is the P wave that conducted. There is a P wave conducted. P wave conducted. And then when you find the P wave, there is no T wave without any P wave. You can go backward. You can see the P wave now. So that's a little bit of imagination required here. So it's a short run of atrial tachycardia with one-to-one conduction. So another ECG, same. If you see that there is P wave inverted in 2-3 AVF, so it's an atrial tachycardia. But what's happening here, I'm going to follow the rhythm stability 2, inverted P wave coming, and then it stops. And then there is a possible sinus P wave, then there is a premature beat. This is a inverted. And then sinus beat, and another premature beat. So you look at the morphology. Now, people always ask me, is it multifocal tachycardia? To define multifocal atrial tachycardia, you will have to have more than 2 morphology of QRS complex, P wave. But this is only one morphology. So this is basically sinus rhythm with runs of atrial tachycardia and atrial premature beat. Anybody wants to do this one?
Dr. Mehnaz Firdaus, কালকে থেকে আপনি অনেক ট্রাই করতেছেন। আপনি এটা মিনিমাম রিড করতে পারলে আপনার জন্য পুরস্কার। Just participate here.
Sir, this is SVT.
Okay. Now, rate is 182 beats per minute. I don't want a direct answer. I want to know what you are thinking. So 182 beats per minute.
Sir,
Right?
QRS complex is narrow.
Is it regular or irregular?
Sir, it seems regular.
Good. So regular. So it is not atrial fibrillation. The QRS duration actually is not narrow. If you look here, lead 1, it's at least 3 boxes. So it is 120 milliseconds. Actually, this is the wide QRS tachycardia. And what kind of wide QRS? What do you think of lead V1? RSR pattern in lead V1. Why is this? Why is the QRS wide with the RSR pattern in lead V1?
There is a block, SVT with block.
What kind of block?
Sir, possibly RBB.
Yes. So right bundle branch block. So this is a tachycardia, wide QRS tachycardia, but right bundle morphology. Typical right bundle RSR pattern, and in lead V6, R followed by deep S. So this is right bundle. So your diagnosis is supraventricular tachycardia, right?
Yes, sir.
With underlying right bundle branch block?
Yes, sir.
Why not ventricular tachycardia? It can be, right?
Yes.
Because it is wide QRS. So, but when I give adenosine to this patient, you can see we block, and then still we have right bundle, and it was an atrial tachycardia that we could distinguish. So sometimes you need help. I mean, what we do, we look at this ECG, we say it is a supraventricular tachycardia. And that is good enough diagnosis. I mean, but you have to carefully look at it. It may suddenly look wide, but it is narrow, but it is not narrow. It's a wide QRS tachycardia with right bundle morphology. And it was an atrial tachycardia after giving adenosine. Somebody to do this one. Noshin, has she done anything?
Assalamualaikum, sir.
Namaste. So the heart rate is a little bit over 150 beats per minute, close to 160 beats per minute. And you start from there.
So the rhythm seems to be regular.
Okay.
But I can't see any definite P waves in front of the QRS complexes.
Do you see anything behind?
Yes, sir.
Where?
There is mild distortion in
Where?
lead 2.
Beautiful. So absolutely right. So you're looking at something, possibly this one, right?
Yes, sir.
So what do you think? And it is very close to the QRS complex.
Yes, sir. This is short RP. So
here you will not use that term. When you see that close, you don't use that term. What do you? It is almost over QRS. So what is the diagnosis?
It's a junctional tachycardia.
A little bit better one. Junctional tachycardia is a specific term that is seen mainly in pediatric patients after surgery. That's not very common in adult. I want another diagnosis.
Okay, so AVNRT re-entry tachycardia.
Absolutely, AVNRT re-entry tachycardia. So look at this. So same patient, when the patient converts back to sinus rhythm, you cannot see the terminal distortion.
Yes, sir.
So you are very right to see this negative component here. And we cannot see it in any other place. So what happens? This is what happens. That you can have, AV node can have slow pathway and a fast pathway. And between this slow and fast pathway, you can develop a re-entry circuit. And once the re-entry completes, once it comes here, it goes below into the ventricle, and it comes up into the atrium. And they can come, depending on which way it takes faster or same time. If they come exactly at the same time, you may not see any P wave. If going backward takes a little longer, like this one did, like this one did, you may see a P wave. So if it went together, you will not see anything. If the QRS took longer, you may see a negative P wave just before, but within 80 milliseconds of the QRS complex. And that's very typical of AV nodal reentrant tachycardia. Thank you. How about this one? This rate is about close to 200 beats per minute. Who wants to do this?
Dr. Partho.
Rate is about 150 above, and
it's close to 180, 190 beats per minute. Fine.
RR is regular.
Good.
And that is P wave after QRS complex, which is distorted and negative, and there is RSL pattern in B1.
Yes, but where is the P wave? How far out?
Just after the QRS complex.
Immediately after QRS, so you think this is the P wave or this is the P wave? Can you see my pointer?
Yes, sir. This is.
So this may be the P wave, right?
Yes, sir.
So is it a RP longer than PR, right?
Yes, sir.
So what is your diagnosis?
This AVNRT with right ventricular block. Clinical diagnosis SBT with aberrancy.
QRS actually fairly narrow. This looks like positive, but I'm talking about, is it AV node reentry or atrioventricular reentry?
একজন আনসার দিয়ে দিয়েছেন অলরেডি, মাহমুদুল হাসান আমিন, AV node reentry plus RBB.
Okay, AVNRT with RBB. Okay, so this, I mean, it's tough to say where the P wave is, but I thought the P wave was in the ST segment. It's a long, short RP tachycardia, and I thought probably this is atrioventricular reentry. And this same patient, when they convert to sinus rhythm, you can see there is WPW syndrome, short PR and delta wave. And this actually is a case that we did EP study, and this was induced during electrophysiology study. What happens is when there is an accessory pathway, electricity can go down through the AV node, and then it comes back to the accessory pathway. It takes time to come back. You see, when the reentry was in the AV node, it comes to the atrium very quickly. And that's why the P wave is very close to the QRS complex. But when it comes through the accessory pathway, depending on where it is, if it is lateral pathway, it will take much longer time. And the P wave will be in the ST segment, just like in this case, and resulting in short RP tachycardia. So this is atrioventricular reentry. Of course, alternate diagnosis will be AV node reentry and all other things that we can talk about. SBT emergency management is, I just talk about briefly, give adenosine 6 milligram, 12 milligram. Most of the time, the reason adenosine doesn't work is because we give it too slow. So make sure that you connect adenosine with a 3-way stopcock, a 20 cc flash of saline, and then the medicine. And if it is in the arm, elevate the arm and inject it. You will see it will always work. And sometimes we give delta or verapamil IV. The problem is that most of these patients have low blood pressure, and once you give delta, it will cause it may cause more hypotension. Adenosine will always work. And if the patient is electrically hemodynamically unstable, then we can do electrical cardioversion. In the long term, we can try beta blocker, calcium channel blocker, but the best treatment these days is radio frequency ablation. I think we're going to stop here today. And if you have any question, I'll take it.
Sir, assalamu alaikum.
Understand?
Sir, I want to know about the antidormic and orthodormic tachycardia in regards of SVT.
Okay. So antidromic and orthodromic. So here, it is coming back it only applies to atrioventricular reentrant tachycardia. So what's happening here? It is coming back through the accessory pathway, going down through the AV node. Okay, and it can go other way also. So what is happening is that anti means anti of normal conduction. Okay, so if the accessory pathway, if the conduction happened down the accessory pathway and coming back through the AV node, it would produce a wide QRS tachycardia, because when it comes to the accessory, and then orthodromic will be this one, which is this example that it produces a narrow QRS tachycardia. So this is orthodromic tachycardia. That means it's going down through the AV node, coming back through the accessory pathway. But this term will not apply for AV node reentry or atrial flutter or any of those. It will specifically apply for WPW syndrome, not concealed pathway, manifest accessory pathway. Okay, anybody else?
So, Dr. Arafat, do you have any question?
Assalamualaikum, sir. This is Dr. Arafat. I have a question. We usually give adenosine 6 milligram first. Then, if it does not work, then we give 12 milligrams, sir. So, my question is, how many times we can repeat this adenosine, and when we will transfer to other measures if adenosine fails, sir? Thank you, sir.
Well, I mean, the question is how much adenosine give. I mean, as I say that 612 will always work. I have rarely given 18 milligram. But as I told you, that only reason it will not work is, first of all, it is not an SVT. Because if you give adenosine, I showed you the example that patients who have atrial tachycardia, we could not stop the atrial tachycardia, but we slowed down the heart rate. Second reason for it not to work is that we are not giving it too fast. So that is the other reason. But once you have given 18 milligram, there is no point of giving anymore. Then you look for something else.
Sir, thank you, sir.
Sir, last question, sir. Sorry, SVT with pregnancy. What is the treatment option?
Oh, pregnancy is a different field. During pregnancy, you will have, if somebody has infrequent supraventricular tachycardia, they can have more tachycardia during pregnancy. And the best treatment is no treatment at all, if we can afford it. And you have to understand that no drug is safe during pregnancy. So if patient can tolerate it, leave her alone. The drug that is been used is digoxin. It's for a very unusual reason, which nobody can explain. During pregnancy, digoxin is a very good drug for supraventricular tachycardia. That's the only drug that can be used. All other drugs have side effects. And then depending on the trimester of pregnancy, you can use beta blocker. But remember that it can cause low birth weight. It can cause problem during delivery. If you are using beta blocker, that should be stopped before the delivery time.
Sir, thank you, sir. It's 10 a.m.
Yes, I believe. Thank you very much.
Okay, sir. Thank you very much.